Hello and welcome to another episode of Hair Talks by Terra Medical. My name is Dr. Joshua Chong, and today we're discussing a clinical problem that I do see in clinic fairly often when patients present to us after not having any results with their healthcare provider, either a general practitioner or a telehealth provider, or even self-treatment at home using herbal remedies or over-the-counter minoxidil. And what's not known to them is that they are actually afflicted with a condition called Scarring Alopecia, also known as Cicatricial Alopecia to those that are medically trained. And this condition may or may not respond to various treatments, but importantly, what the patient must realize is that the diagnosis of Scarring Alopecia must be made by someone who's familiar with diagnosing hair loss conditions. And in this video today, we're going to be delving into different subsets of Scarring Alopecia, which is quite a common hair loss disorder. So what are cicatricial alopecias? Pardon the jargon. These subset of hair loss disorders actually involve a process that destroys the hair follicle completely, rendering it not recoverable. Even in the use of medications like finasteride, minoxidil, or even with regenerative type treatments like Tricopad or PRP or Regenera AMT, recovery is seldom seen in these patients. That's because cicatricial alopecia, which undergoes an autoimmune process where an immune reaction, if you will, or immune cells actually damage the progenitor cells, a very crucial component of the hair follicle. And that destroys the entire hair follicle architecture, making it look poreless under a trichoscopy, so you don't even see the opening of the hair follicle, and can be also associated with other skin changes. The other skin changes that might happen with cicatricial alopecia include itching, burning sensation, scaliness, flakiness, and sometimes you will also see under trichoscopy an increased amount of blood vessels in that area. So there are many different types of cicatricial alopecias. We'll talk about the first one and the most common one that I encounter in clinic first, and that would be frontal fibrosing alopecia. And that's a condition that's been associated in recent years with the Slip Slop Slap campaign, where people are applying chemical sunscreen to their whole face, including their eyebrows, their beard area, and their hairline area, temple area. And what happens is, it is proposed that the theory is that this sunscreen is actually toxic to the hair follicles by a mechanism that is not completely understood, and the hair follicles actually undergo slow destruction. The characteristic feature is that it's a completely bald area across the temple and hairline, and sometimes the eyebrow. You also see destruction of the mustache and beard, and that's called facial alopecia. And you might get some facial papules or brown protruding marks across this part of the malar process. Some patients might also notice that there will be redness across that area, and when you look at it under a microscope, you will see scaling around certain hair follicles. The characteristic trichoscopic finding of a lonely hair is commonly seen, and you see that the skin actually appears quite shiny across what used to be the hairline. This condition can be rapidly progressing or can be very slow progressing based on the American Society of Dermatologists guidelines. So very rapidly progressing would be defined as more than 1 centimeter per year, and there are also slow progressing variants where the hairline doesn't recede too much. And they would be treated in a similar fashion. We want to stop the progress of this alopecia first. We don't want the hairline or the temple to continue receding. We want to observe that, and if it's kind of slow or it's quite stagnant, then the only remediable way to reverse that hairline recession is by way of a hair transplant. However, in the meantime, we also start our patient on a variety of treatments such as immunosuppressive treatments like local injections of steroids or tacrolimus. We can also use things like dutasteride or finasteride to help to protect the hair follicles, and certainly the use of minoxidil to increase and encourage the growth of weakened but not completely damaged hair follicles. So frontal fibrosing alopecia can affect both men and women, and if you notice that your hairline is receding at quite a rapid rate, you don't have a family history of hair loss, you may not know whether or not this is male or female pattern hair loss, or this is frontal fibrosing alopecia, do consult a health professional that's skilled in diagnosing hair loss conditions. Sometimes we might need further testing apart from just a trichoscopic examination to confirm that, and that would usually be a biopsy where we take a small sample of skin and send it off to a dermatopathologist to look at it under a high-powered microscope, where they stain it for different things and identify whether or not there's actually active disease there or whether the hair follicle architecture is still present. The next most common condition that we meet in our practice would be LPP, or lichen planopilaris, and that's a condition that's quite similar pathologically to FFA, where there is scaling, erythema or redness, inflammatory conditions that actually scar the hair follicles, but tends to occur mostly across the crown or the mid-scalp area. It's quite frequently associated with a sensation of itching or burning on the scalp, and this process has a slow destruction of the hair follicles, and using a trichoscope we can identify whether the primary pathology here is a scarring process or a cicatricial process versus female pattern hair loss, which also tends to appear in the same distribution across the midline, spreading in an outward fashion. And the treatment for this would be similar to FFA, where we use a bunch of different medications. In the context of LPP, we do intralesional steroid injections or triamcinolone acetonide injections. We also consider the use of other immunosuppressants. We can use dutasteride and we can use naltrexone to help those people that have very quickly progressing disease. And it would only be considered for a hair transplant if the disease was stable for more than 2 years. If the disease is still progressive and there's still features of active disease, a hair transplant is going to result in almost complete failure. The next topic we will touch on is folliculitis decalvans, which is actually a condition that is triggered by infection under the skin. Typically, it will be a folliculitis, so kind of like an acne within the hair follicle, and that spreads under the skin, and the scarring actually causes hair follicles to tuft up together. So under the microscope, you see a bunch of hairs that are in orders of 10, for example. And there are no hair follicle units that actually have 10 hairs emerging from the same hair pore. This effect is due to collagen being laid down and dragging the hair follicle units closer together and destroying surrounding hair follicle units, causing permanent scarring to that area. And this scarring can be treated with a hair transplant, but that's only if you solve the underlying scarring alopecia first. And usually that will be done with a course of antibiotics, and it can be quite as long as 6 months or more if the infection was quite deep set. Sometimes steroids are also used to make the scar a little bit flatter. In folliculitis decalvans, we sometimes see that it is raised, protruding out from the surface of the scalp. And the area that it affects also determines whether or not we will use hair transplant techniques in order to recover the scar area. And the fourth most common clinical situation that we see in clinic that is frequently misdiagnosed as female pattern hair loss is FAPD, or fibrosing alopecia of pattern distribution. It looks almost identical to female pattern hair loss, and sometimes even under the trichoscope we have difficulty differentiating whether this is female pattern hair loss or purely scarring alopecia. And sometimes it's a mix of both. There is female pattern hair loss going on in which you will see anisotrichia or difference in the caliber of hairs across a certain area of the scalp. So some thick hairs and some miniaturizing hairs kind of tells you it's female pattern hair loss. But when you see some areas where there's no pore or no hair follicle ostia in medical terminology, then you would suspect that there's a scarring process going on. And the confirmatory test is again a biopsy. So that biopsy sample is sent to the lab for the dermatopathologist to give their expert opinion on. And if this is indeed FAPD or fibrosing alopecia of pattern distribution, the treatment would be a little bit different from that of female pattern hair loss. We would actually be telling our patients that, our role here is to limit the damage of hair loss, not allowing it to spread even more, but the prognosis in FAPD patients is not as good as that of those in female pattern hair loss sufferers. And that's quite a lot of information to take in this episode. We talked about the 4 most common clinical presentations of cicatricial alopecia in Terra Medical. And stay tuned for our next episode where we discuss other very important aspects of this topic, scarring alopecia. Thank you very much. If you've liked this episode, click like and subscribe to our channel for more hair loss and hair related content. And if you've got any questions, leave them in the comment section below.